Kia ora koutou katoa. This morning I have the privilege of introducing Professor Boyd Swinburn. However, he really needs no introduction. When I contacted Boyd last week, he generously replied that I needn't read his entire bio as he was reasonably well known with this audience. I think that's probably the understatement of the day, as I'm sure most of us here are familiar with Boyd's work. Boyd's a professor at the University of Auckland and Alfred Deakin Professor at Deakin University in Melbourne. And of great interest to us all here, Boyd's research has centred on community and policy actions to prevent childhood and adolescent obesity and to reduce obesogenic environments. So today Boyd is presenting on systems approaches to obesity prevention and what this actually means. So please join me in offering a warm welcome to Professor Boyd Swinburn.
Kia ora tātou. Thanks very much indeed, Carmel. Thanks, Matt, for warming everybody up. It's a pleasure to be here, and thank you very much for this invitation. I always enjoy coming to ANA conferences. There's a lot of great things happening. You hear a lot of fantastic things that are happening around the country, and I look forward to that in this conference as well. Before I start, I know that the conference organisers are being trolled by Carrick Graham about my presentation around my conflicts of interest. So just to let you know, I have no commercial conflicts of interest, but what he's probably concerned about is that a few of us people in public health advocacy in court proceedings with Carrick Graham and Cameron Slater and Catherine Rich and the Food and Grocery Council for defamation, just to put that on the table. Okay, so I'm here to talk about systems approaches to obesity, obesity prevention, what this means. I'm not a systems scientist. I'm just learning about this stuff myself and learning about how to apply it to obesity prevention, which I've been involved in for many years. So I'd like to just share some of those insights with you. And there we go. Okay, so I'm going to talk a little bit about the pre-system stuff, where I did a lot of work in Australia, thinking about what I call Generation 1 and Generation 2 systems approaches, thinking about their sort of package testing and community capacity building. But within those, particularly some of the work that we did, we started to see signs of systems change without necessarily really recognising it. I'm going to talk a bit about systems thinking and tools, what that means and how that might be different, and look at Healthy Together Victoria, which is really the first large at-scale approach to obesity prevention. We'll then put it into context of the New Zealand scene and try and draw some conclusions about where we go next, because I think it's actually really quite exciting. There's a lot of excellent things happening out there. So if you look in the literature about childhood obesity prevention, you get things like this Cochrane review, pulling all the studies together, some successful, some not, almost all of them short-term, and on average, that little diamond is to the left of the line, meaning that on average they work. But the main thing is that almost none of these have been sustainable. None of these have sustained. They've been generated by academics largely, come out taking this package of activities or programs that they've worked out in the ivory tower, implemented them within schools largely, often less than 1 year, published the results, and because they were free of context, free of whatever else was happening around them, never kind of went any further. And the same is true with not so many studies in preschool and adolescence, but the same kind of pattern. So this kind of approach, which dominates our literature, is not the type of approach. These are still very useful in testing these ideas out, but this is not going to lead to wholesale systems change. So based on that and some of the earlier work, we developed a number of whole-of-community approaches when I was in Victoria, and these are three of them up here, three that we did, three long-term, over 3-year studies with comparison groups in 3 different age groups of children, largely low-income white populations in rural Victoria, under 5s, that was the Romp and Chomp program, primary school-aged children, COLAC, and It's Your Move, which is secondary schools. So each of these actually had a significant effect on reducing BMI and reducing obesity over 3 years. The top one, Romp and Chomp, was a very low-funded project, like $100,000 over 3 years to try to reduce obesity in 12,000 children in Geelong. And that forced us to get into what was sort of a systems-based approach, even though we didn't know it at the time. Be Active, Eat Well was the first one we did actually, and I'll show you a little bit of follow-up, what happens when you go back 3 years later after the end of this project. You know, the project money comes in, lands plop in a community, and then the money finishes and what's left at the end. So I'll show you what happens after 3 years. And then It's Your Move, which is in adolescence. We also use this same approach in Fiji, Tonga and South Auckland. So just that last one first. So this is the teenage one, this Australia to the left there. I showed you the significant reductions in overweight and obesity over 3 years. All of the rest of the communities where we tried this capacity building approach, which was about building leadership, strengthening partnerships within the community, mobilising resources, building skills and so on, had no effect, no discernible effect. And even amongst the Tongan population of 15 and 16-year-old kids, they went from 65% overweight and 55% to 65% in the intervention group over 3 years. So this caused a little bit of head scratching. I lost a bit of hair over that time. This was a good decade of work. I could show you 1,000 photos of all the great things that were happening, but when you take the hard measurements, it just wasn't enough to make a difference. As I said, with the Colac one, the primary school one, we went back 3 years later to the intervention area, which is a little town in southwest Victoria, and the comparison area was the whole region around it. We went back and we measured the commitment, the investment. So this is money and people's time for a cost-effectiveness study. So here's the investment in Colac in the dark bar and over the period of the intervention. And you can see when we went back 3 years later, it had reduced by half, but they were still doing stuff. And actually their capacity, as we measured it, was still pretty good. But what really surprised us was this comparison group, who of course were doing nothing at the time that we had the intervention. Went back 3 years later, they were doing twice as much activity in the comparison town. This stuff had got out through the grapevine, had gone through the networks. They'd picked themselves up by the bootstraps, and they had mobilised their own resources, mobilised their own committees, and found their own way to do it, and actually had substantial results. So here's Colac. So the top two bars are the overweight plus obesity. That's in 2003 at the start of the intervention, plus 3 years of the intervention, plus another 3 years takes us to 2009. You see they've reduced overweight and obesity by 6 percentage points. 6 percentage points over 6 years, that's not bad. The comparison community actually reduced by 10 percentage points over 6 years, which is incredible. And it says to me, and this has happened to me before, where comparison groups have done better than intervention groups. And it says something about the self-efficacy, picking yourself up by your bootstraps, working out your own ways to do it. I think there's merit in that. We need to understand that. We then went on and did a bunch of other types of interventions, and following the Be Active, Eat Well one, the Victorian government said, this is great. What we need to do is to scale that up, multiply it up. Let's do another 5 communities. And we tried that and actually made no difference. And in retrospect, when we went back and analysed it, this was quite a different job, there's quite a different model to what we had done originally. This was government contracting each specific community to do, a program of work, as opposed to the community developing it itself. And we spent so much time in all the contractual stuff and all the bureaucracy that went along with that actually seriously got in the way of the action. So that was not this concept of multiplying up. I don't think, particularly if it's kind of done in that kind of contractual way, doesn't really help. We had a metropolitan in Melbourne, a multicultural intervention. A lot of complexities when you add in metropolitan areas, a lot of complexities when you've got multiple cultures, and over time that had very little effect on reducing obesity as well. So some of the stuff that we had been doing in this pre-systems thinking approach was getting through, but not enough. And we needed to work out better ways to do things. So we used the systems building blocks, which we call capacity building blocks, leadership, mobilising resources and so on. When we went back in retrospect and looked at the process minutes of these, all the process data from these successful ones, there was an enormous amount of argy-bargy between the organisations about who's doing what and who's taking what and what logos are going where and who's responsible for this and how much duck shoving are you doing and why should we do this stuff and so on. Actually, I think in retrospect those were signs of systems change, that almost you can't get from point A to point B with a systems change without some jostling and argy-bargy. So this may actually be a good sign. We use quasi-experimental designs, pretty standard epidemiological tools. I don't think they're sufficient as we move into the systems approach. Some of them are low cost. This concept of an obesity prevention virus spreading out through the networks we kind of clicked onto, but we hadn't really articulated what exactly that meant, which we did later. Quite a few limitations in this. Obviously not nearly sufficient for non-white communities. Wasn't culturally centred enough, I don't think. Didn't arise out of the cultural strengths. And the kind of government-managed one-on-one contracting to communities, I think, is not the right model to try to scale this up. In fact, the whole concept of scale-up as opposed to at scale, those are two different things. And this kind of multiplication may not be the way to go. However, at that time, kind of systems thinking landed on us, and we're thinking about how does that apply in community-based approaches. And can it be done at scale? Can it be aligned with cultural perspectives? And can it be sustainable? So just to frame these first couple of approaches, so the package delivery that experts like me sitting in my ivory tower developed the thing based on my super-duper knowledge, and we deliver that, and it might be some behavioural change, predisposition change, some environmental change. That kind of approach is valuable for testing various things, but not if you want to get sustained change. The capacity building tried to incorporate capacity change, and now the systems approach is taking systems change. And is this the one that can be more inclusive of culture, be more inclusive of the dynamics and context and so on? So at the time that these were sort of finishing the systems map, this was the first, and Hayden already showed this is the first sense of obesity as a complex adaptive system. And we hadn't really thought about it in those terms before. But when you really think about it in systems terms, as I'm learning the systems language, obesity is essentially an emergent property of a complex adaptive system. So emergent property means that's not what we think the system is designed for in the first place, but actually the way that the systems operate, this is an obvious outcome. This is a natural consequence. This is what they call the goal of the system. It's not the goal of the organisation or the government or the school or anything, but it's the goal of the system as we set it up. And the goal of the system can be quite different to the goal of an organisation. So, for example, you take school food. Most schools have some school food system. A lot of them are there to, if you look at the system per se, then some of them are designed to feed kids, to make money for the library, and to make kids fat. If you looked at the system and analysed the system, those are the three outcomes, the three emergent properties, two of which we want, one of which we don't want. So we need to align the system goals with the organisational goals. So when we talk about a whole of systems approach, we're considering the whole as well as the parts. We're considering the sum and how they interact together. We're considering the dynamics within it, the rules and the boundaries and so on. And actually for me, my original training was in endocrinology. And endocrinology is such a beautiful science, and physiology is just so beautiful because it is a whole set of complex adaptive systems. Lots of balancing loops that keep our whole physiology very stable in the face of 1,000 moving parts that are interrelated, the whole system is relatively stable. And communities are like that, and systems are like that. So I found the thinking actually relatively easy to translate to communities. Concepts of feedback loops, delays, nonlinear effects, tipping points, and so on, and this idea of patterns and emergence. So I'm just stealing a few slides from David Rees, when he tries to describe systems thinking and systems approaches. So here we have two piles of sand. There's a big pile and a small pile. So if you cut that pile of sand in half, you still end up with the same thing, a pile of sand. So the components are the same, the structure and the form and the texture and everything is the same. You cut it in half and you've got the same thing. If you take a cow and cut a cow in half, you have not got the same thing. You've lost some cowness. You've lost any sense of the working of the creature as a whole, of its system. Thanks very much. And you can't examine cowness by examining just the bits and pieces of it. If you rearrange the sand, those little bits of sand, into something that has structure and form, then this is now starting to become more like a system, because you cut this in half and you don't have two castles. You've got one castle, you cut it in half, you haven't ended up with two castles. You've lost some of the structure and the form and the wholeness of it. Or you can look at another thing. That's still a castle, that's a castle, and that's a castle. They have similar overall properties made of completely different sort of substances and so on. So it does force us to think about the whole. Now, there are a lot of fancy techniques that are applied within systems science. As I said, I'm starting to learn some of these. These are only new really to health, or relatively new to health. These have been around in engineering and ecology and business research for decades. And for some reason, we just haven't applied this to health. We have a little bit to health systems, but not to health as we're trying to do it in the prevention sense. Now, some of the main ones that we've been using are agent-based models. I'm not going to talk about that, but that's where you give characteristics to each agent and you build some model. I'll talk about some systems dynamics approaches and network analyses. These are new sets of tools, tell us very different things about the structure and nature of systems and how they change over time. And one of the big things about shifting thinking into systems is to think in a dynamic way, which adds to the complexity that we've got to fit inside our heads. And this guy on the left, the socio-ecological model, has been around for 40 years, and we love it because it's simple. It helps us explain a lot of things. It helps us explain the individual differences in here because they're related to where that person's come from and their community and the whānau and the wider policy and environment and so on. But they don't really tell us about the dynamics, what causes what. And when you shift into systems thinking, like with causal loop diagrams, you're forcing yourself to think in dynamics as to what is causing what, in what direction, and so on. And you're forced to start to identify feedback loops, reinforcing and balancing loops. And it gets very complex very quickly, which is why a lot of these models, but the computational models, can get pretty serious. So what does it mean? I think it means a lot for the way we think about our interventions and how we deal with our interventions, but it also means a lot for evaluation. Because now suddenly, if we're talking about not just one little community where we've got some comparison, let's say we want to do something across Auckland. What's the comparison? Or across the country? How do we implement something at scale and still evaluate the change? And this, we have to use some of these systems tools, I think, to help us, at least for some of these proximal changes, so that if you think you know what you think you're implementing something about changing a system, can you actually measure and show that system's change? Can you show how it happened flowing across the network and so on? Can you measure then the changes in community capacity and down to behaviour and BMI and so on? But those left-hand side things that we need to intervene on in the systems and the capacity, we need better tools to understand that. And I think that's what these tools will help us to do. Instead of thinking about intervention and comparison, which is our classic experimental or quasi-experimental approach, we need to think about explaining heterogeneity. So if you take a city like Auckland, then it will be changing over time in some outcome like childhood obesity at quite different rates, at quite different paces in different micro-communities. And that will be determined by contextual factors and things that are happening. Understanding that heterogeneity and the dynamics of that heterogeneity will help us understand what is driving those successful communities and what's holding back the unsuccessful ones. So it's not so much this pre-post intervention comparison approach. So this null hypothesis testing may not even be possible. Explaining heterogeneity, thinking about the how questions, not does this affect it, but how does it affect it? If we think this is the way to go, then the question becomes how do we best implement it? Using monitoring much better than we have. So Healthy Together Victoria came about. It was a particular fortunate coming together of several factors. First of all, the federal government in Australia had decided in its enlightened approach that prevention was a good thing for the economy. They had the governments, the Council of Australian Governments, federal and state governments, periodically have these big pushes for improving the economy. The first big push was around reducing regulation. The second big push was around getting healthy workers and healthy communities, so they're not so much of a drag on the budget, and also gave better productivity to the economy. And from that flowed nearly $1 billion over 9 years, which was a long period of time. $1 billion in the Australian context over 9 years is not a lot of money. It's a small amount of money, even in the health budget terms, but it's a lot of money for prevention. And it really gave a shot in the arm to the states who were going to try and do things. So in Victoria, we just had all those studies and all that history and the people that had been trained and that knowledge that I'd talked about with those community-based interventions, things we'd tried, things we'd failed at. And we also had, highly fortunately, a senior bureaucrat who just did a PhD in systems change for prevention. She happened to be nuclear powered, she happened to be a redhead, and she just drove this whole systems approach across Victoria with a super passion. And it was amazing to see the transformation. A lot of argy-bargy, a lot of pushback from councils who were the main focus of where the money was going and so on, and we're now expected to do health promotion. We're just a council. We look after the rates and the roads and the rubbish, not health. And so there was a lot of pushback, there was a lot of argy-bargy, and it went and it worked. It has a couple of years in the development and was running for about 3 years. It covered nearly a third of Victoria. They picked out high-need areas across the state and targeted them. So it was an investment in a systems-based approach. The health minister was he was actually a chiropractor. He was a fairly wooden sort of guy. He didn't look like he would cotton on to much, but he seriously cottoned on to this. He actually really understood systems approach, and he was a total champion, the biggest health minister champion I've seen in a long time, which unfortunately in the end counted against the program. Because this thing was just gathering speed, and there were a lot of other communities that were not involved, that wanted to be involved because the word got out. Election time, Liberals got out, Labor got in, tossing the whole thing out. And the whole thing fell over, largely because it was sort of, I think, Some of the funding was pulled federally. That gave them the excuse to pull it at state level. But it was kind of politically associated, which we thought was a great thing at the time, but turned out not to be. So I think we need to be wary of that. However, the prevention virus, as I said, had already started to spread. The other communities wanted a slice of the action. So when it fell over, there were a whole lot of other communities that got activated to want to do something because they started to get the bug. One of the other things that counted against Healthy Together Victoria, when it came to the crunch and a budget time, there was no hard evaluation to put on the table. There were no data, compelling data to show why this needed to be continued. And so the lack of investment in evaluation and good evaluation was actually also part of the downfall, I think. So this idea. So we're involved in trying to support them, and also New Zealand picked this up, which was fantastic before the whole thing fell over, and we're now the champions of that and carrying that for the world. I'm just going to quickly run you through one of the tools that we use quite a bit called group model building, just to give you a sense of what it is. Now, some of you maybe have done this and have been involved in this, so apologies for that, but this is an approach to build a causal map or diagram, participatory with the local people, and it starts them by thinking about changes over time, what's happening in your community, what is changing over time, where do you hope it's going to go, where do you fear it's going to go, starting people to think about dynamics. And then they just say, okay, what are these dynamic changes that are happening over time? And they just put them all down in a circle like that, and then they get their pens and their papers and they draw lines across it saying this is connected to that, this causes that, if this goes up, that'll go up, if this goes down, this will go down, and so on. They just start drawing these causal diagrams. This causes that. Dynamics over time. And a little bit of playing around with the computer starts to look a bit prettier. And then over time, as the community builds and builds on this, it gets rapidly more complex to this point here. So this is from Portland, another small town in the southwest of Victoria. This is their map. This is their plan of action. All these green dots are the actions that they are doing in Portland, this little town. And they built this. This is their map. I don't understand it. I don't know what it means, and I don't pretend to know it, but they do, and it's on their wall, and that's how they build their system. And they say, okay, we've got a problem over here with sugary drinks. Let's examine this piece of it. So they dive down into here, and this is what they've got: water consumption, sweet drink consumption, the factors that kind of lead into it. So then they say, okay, what are we going to do about that? We need to do something about sugary drinks. So they build the intervention up here at the top in a systems way. They think about the reinforcing loops. They think about the balancing loops. They think about the injection of data that are needed and so on, and to reduce sugary drinks. So it's thinking about it in a systems way. And how does that impinge upon this system here? And also access to free water. So they said, wow, that one worked really well, and we got rid of the sugary drinks. How do we promote water consumption? So they started thinking about it in a systems way, and then they said, oh, hang on a minute. That one before that we did, we kicked the whole thing off with some good monitoring data about sugary drinks availability. Maybe we better do the same thing with water and do a tap audit and so on, and take that to the leaders and get them to activate. So it forces them to think in a systems kind of way. This is another model. This is drawn by David Rees for CVD. This is in South Auckland. But he took this particular approach. You won't see all the bits in there, but you see all the question marks that are centred around that. Each of those question marks actually are data. So what that does, you can convert those big messy diagrams actually into a computational model by adding data for each of those lines. I haven't got all the data there, but then you can start to get predictive. You can start to run the model and see what the scenarios are over time. If you change this, if you change that, and so on. That's where we kind of need to get to, I think, at some stage with obesity prevention, but it's some time off. We made a little bit of a start of this in Auckland with under fives, building a causal loop diagram. When you build these things with communities, the interesting thing is that we always think about the reinforcing loops. We kind of automatically think about what causes what and what causes what in a reinforcing kind of way. You know, if we have perceived value of food, and then we have food nutrition policy, then we lobby for some more dollars, and that will reduce and that'll increase knowledge and skills gaps and skills and more food in there, and we end up with this reinforcing loop. But we fail to think about the balancing loops. What are the barriers? What are the time delays? Why is this not happening? And so it does force you to think about, and we often in health promotion don't give enough time and thought to these balancing loops. Anyway, when we built this, what was missing actually was this little arrow here from the provision of nutritious food to the perceived value of nutritious food. And when we laid it all out, this is just one small piece of the diagram that they built. This is just around the food in the ECEs. When we laid it out, that arrow wasn't there. They said we start off here, perceived value of nutritious food, and that will lead to nutrition policies and promoting of the cooks and so on. But if you add this arrow in here, then you create a reinforcing loop where you end up with a virtuous cycle. So how do you close that loop? What is needed to go from the provision of food in the centre to a greater appreciation of the value of it? Maybe it's good stories, maybe it's evidence about its impact. There's things you need to do in that space to create that loop. So this is kind of thinking in systems type of approaches. We started looking at where the data are to try and make this numeric. And Sarah Gerritsen, who works in growing up New Zealand, did this. And we've actually got quite a few variables we can already insert into this. It's already part of the way on to thinking about a quantitative model. Okay, where am I? So that's one kind of tool, these causal loop diagrams. Another set of tools is thinking about these networks and what flows across the networks. So when we went retrospectively back to look at those earlier studies that I'd said, the successful ones, we asked the question about how did this happen? How did this happen? We went back through all the process notes on those interventions and some in Boston as well. And what we found was that the key factor was the steering group, management committee, some group at the centre of committed people who were prepared to take on this kaupapa and drive it, despite all the argy-bargy and the organisational hassles and all that sort of stuff, all the inevitable things that come along. And how did they do it? Well, those people were networked. They went back to their own organisation. They influenced their own organisations to act. And what are the things that flow over those networks that made activation possible? So there's two things. One is knowledge, which is not just academic knowledge about what's causing this and how we do something about it, but also local knowledge about what's being done, how to mobilise resources, who's who in the zoo, and so on. So all that encompassed in knowledge can flow over networks. The other thing that can flow over networks is what we're calling engagement. So that's the degree of participation, the dialogue, the mutual trust, the energy, the self-efficacy, the can-do type of thing that flows over the networks. And if we can characterise these and support the growth of these and support the network development, then we're starting to talk about this obesity prevention virus spreading. So here's knowledge, and this is the under fives. So this was kind of some of the measures of their knowledge. So they knew quite a bit about the problem of overweight. They knew less well about where to intervene, what to intervene and what the determinants were, and about sustainability or what others were doing or where the resources were. So plenty of scope for increasing knowledge across those networks with this group. This is a group of ECE leaders in Auckland. Degree of engagement was somewhat engaged. So a lot of potential for increasing the engagement. But the tools that we found were valuable in this engagement, the issue of flexibility in your learning, dialogue, mutual learning and so on, were actually quite high. So they had the good characteristics, it's just that their level of engagement was quite low. They didn't feel particularly well empowered, some degree of passion, reasonable trust, a little bit of power, but these things can obviously grow over time and actually maybe early indicators of change. We did a little bit of early social network analysis, so there's two types of networks. One is egocentric, where you measure a person and that person's networks, and one is where you measure a complete network and find all the connections. We didn't get up to the sociometric one, but kind of made a start with each of those participants and just saw who they spoke to about obesity, nutrition, physical activity, and so on, who they were linking with, and here all the different type of organisations. So some of them only really talked with themselves, others talked with quite a lot of others. So this is the start of building up an understanding of these networks and how they might spread. And this is what's called the heterophily. So this is people down on the left-hand side there have a relatively narrow group of people, spread of people that they talk with. That may be totally appropriate. It's not saying it's good or bad, but it's just a characteristic of the network. Whereas others have a lot of different people they talk with. And these are the different things that they talk with already over the networks. So that's something to build on. So having this building this pattern, building this picture of these patterns of existing networks and what they talk about is important. Now, apologies for this, a little bit complex, but this idea of cascading through community networks, we need to think about that a lot more, about how we influence that and promote that. Amongst the authorising level, so this is the CEO level, what do they need to know to give the stamp and their mandate to let that proceed? What do the managers and leaders, the steering group, what do they need to know? They're often the system designers and the builders, the people with the kind of passion for this particular topic. And then you get out to staff and parents and volunteers and so on. What do they need to know in the system space? And then whoever's going to do the action. And linking that up with something that I know a number of people are using, this concept of collective impact. If you want to jointly work together in a collaborative way to have collective impact, then pay attention to these things. Have you got a common agenda, shared measurements, mutual reinforcing activities, continuous communication, and a backbone organisation? So these kind of models of how we construct systems approaches with other models that also work very well in other circumstances, like collective impact, is kind of where we're thinking at the moment. So just turning to New Zealand, we've got a lot of positives here in this country. We've got a lot of strengths. We've got a lot of stuff happening. Obviously, Healthy Families is a big one. That's across the 10 communities. It's got good funding. It's got good capacity. It's learning how to do stuff. But there's a lot of other things as well, a lot of other national and regional activities happening in schools, happening in regions. Healthy Auckland Together I know a bit about because I'm involved in that. So how do we take the lessons from what we are learning with these models and this kind of understanding as we learn about systems approaches and build and create the next level? Because New Zealand can actually be a world leader in this if we want to. We've got a lot of advantages in New Zealand. Healthy Auckland Together, I think, has got a lot of prospects. And we're thinking about Healthy Auckland Together now. It doesn't have much money. It's got a little bit of support through the Regional Public Health Service, but a lot of agencies around the table. And we're thinking of this as what they call in the trade an MVP, a minimum viable product for a prevention system. Can we convert this goodwill and these people and agencies around the table into a true prevention system? You know, our health system is a disease treatment system. It's not really about prevention to a large extent. We need to devise a true prevention system. That's where our eyes should be focused. That's where we need to go. I'm not going to talk about Indigenous approaches to obesity prevention. We've got a workshop on that after lunch. This is Albie talking about the causal loop diagrams that they did down in Uawa and Tolaga Bay. I think there's an enormous amount of overlap between Indigenous thinking and the strengths of Māori culture and other cultures to systems thinking, and we need to work out how they can combine together to give strength to each other. So I'm not going to talk more about that. We've got some research projects underway and a number of developments, all thinking about this research systems approaches. So this is an example of Foodback system. So Foodback is an app and a platform which we've used version 1.0. We've got version 2.0 about to be launched in a couple of months when we iron out enough of the bugs. And this is for community members to map their own food environments and create stories, create data about their food environments. Gets fed into a central database. They get a thank you back. Well done, thank you. You're contributing to science. You're improving your local community. We'll in the end get short feedback loops to the school principal or the retail manager at the school or the local council, whoever's got jurisdiction over that particular environment, giving the feedback, the kind of TripAdvisor type of feedback. And then the central database as we kind of manage and understand these data as they change over time back to the change agents. So thinking about how we develop these in a research way to add in the research plus the action in a systems way. So just to finish on the kind of strengths of systems approaches, we don't know how to, I don't think we know how to apply this fully. We're still learning how to use the tools. We're still learning how to adopt the practices. We want to work out how to combine this with cultural strengths and cultural views of health. What we can say at the moment is that it is highly engaging. A lot of these tools that you develop with the community, because they're about the community, with the community, they own them and they get enormous amount of value out of them. So I think straight up at that engagement phase, we've already got some winners there. And particularly with the group model building seems to be very valuable. I think we get a much truer picture of the problem and of the solutions. We start to understand the ways in which childhood obesity, which is just about, isn't it just about kids eating less and moving more? Well, no, it's not. It's deeply, deeply systemic. And unless we grapple with that, unless we embrace that, unless we use that complexity to the population's advantages, like the judo, using the existing movements and dynamics to get a different outcome, I think is valuable. More tools for understanding and evaluation. And there's understanding these different levels of intervention. I haven't really talked about them very much, but in our classic health promotion way of thinking, and in fact the natural places that people go to when they're thinking about interventions is at the variables in those causal loop diagrams, the things in the boxes. That's where we automatically go to think, okay, we're going to increase that or decrease it. But we think less about the relationships and particularly these causal loops and creating the loops or understanding the loops. And at a really deep level, what are the rules that govern the whole system? And what are the goals of the system as you look at the system and what the system is creating versus the goals of the organisation? And can we align those? So that's a much deeper, more pervasive approach across the whole system than just dealing with the variables themselves. So just to wrap up, I think that we need to shift to systems thinking. I think it is a step change in our thinking. We're still learning how to do it. I've got 2 PhD students at the moment within the Department of Health in Victoria, trying to understand how it all happened in that mad rush of a few years in Victoria, how it all happened, how theory was applied to practice, what parts of systems change actually got to the ground and were used, and how they were used. So we need to add the science to our practice. Still understanding how to communicate. This is tough stuff to communicate. There must have been 100 different PowerPoints that we use, different ways of trying to show it. It probably needs animation, actually, to be able to capture the dynamic changes. You can't just get it on a slide. So how do we communicate this idea of dynamic changes? This idea about the prevention virus and capitalising on the networks and the knowledge and engagement that flows over that, I think that's critical, and we're good at networking, and I think we can do that really well. Needing the systems tools as well as our standard tools, as well as our standard linear models and null hypothesis testing. We still need that, but we need to add the systems tools on top. I haven't talked about this at all. This is a big gap for New Zealand. We've got the before school check for weight, which is great. But then what do we do for school kids? We're just relying on the National Health Survey, which we might get ethnic breakdown and SES breakdown, but not this not the really valuable evidence that communities can take. That is our problem. That is our obesity level. We're going to own that and take that and deal with that. I think we need to get monitoring across school kids. And we're at the stage, I think, of having enough lessons learned. We've had enough practice over this in the last few years. It's never going to be a perfect time, but let's get together and pull our lessons and try to create prevention systems for New Zealand. Thanks very much.